Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 181. It's a sizzling hot morning in New York City, and we welcome you all. Have a very interesting, truly educational case. A left main calcified bifurcation and multivessel lesions in the left anterior descending and the left circumflex, all supported with an Impella support catheter.
VL30.
Let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kinney are scrubbed in already. Samin, good morning. Apparently with the new staff today, new fellows.
That is true. Our usual, the yearly change, and of course with the largest program in the America with the international fellows, about 9 to 10. This year 9. And then of course we have 3 structural, 2 endovascular, and then we have imaging fellows and so a lot of fellows. But yes, that requires extra teaching and getting them up to the speed, and it's all so far always had been good in July actually. People think about there will be more complications in July, but we have a lowest in July. Everybody very cautious. We definitely have a little higher in June because I say usually the fellows have checked out.
Shorten the cable maybe.
But with that note, clearly very hot, and we now getting into our case number 181, and we always trying to, initially you saw the announcement, we did make it about the CME that we make it, but it requires some more regulatory issues, so that we will not be able to do today as a CME. Hopefully, the next month, we'll be able to do the this live relay as a CME, which will require basically that you need to attend it, and in the end, you just have to fill up some form. Rest of the staff is rest is of course Anu on my left side, and then we have 2 fellows, Tushar and Swati. And Manish is our super fellow, and the nurses are same. All familiar faces with Will and Ashley, and Tax, Asif and Habib. And imaging actually Yulia. She was there last time also. And we'll show that you can see as soon as we try to show.
Get me an FCL.
Yeah, just 1 second. Keep it there. Can we show the fluoro 1 second? Look at the extent of calcium. Fluoro?
Okay,
No, they need to show fluoro there. 1 second. Yeah.
Okay.
Look at the calcium. Aortic calcium and the calcium on the coronary is good. Okay, let's go back to our presentation. So this, with that note, very calcific lesion, which we'll be tackling today. And let's go back to our slide presentation now.
You have FCL?
Okay, so this is our page views. It still continues about 20,000 plus per month, and the last 22 years has been a very satisfying in 170 about like 90 countries and so, and both US and India actually on the YouTube, little more India on that, but overall these are the various countries which are part of our live relay. So more important to come back to, these are our supporters, and then disclosure no change. Case number 181, 89-year-old patient with presented with the CCS Class III angina and positive stress test with TID. Ejection fraction patient had MI and PCI in the remote past with EF around 50% and multiple risk factors shown there. As you see, what we started showing also now, some lab values in terms of A1C, LDL, CRP, and creatinine, which we do in majority of these cases. Medical therapy is right there, and then of course this patient on the cardiac cath had 2 vessel and left main CAD. And we'll show if they have some angio. Sorry.
This camera.
They are able to show it or no? We have done any angiogram at all?
No.
No, not even RCA picture?
RCA picture we have.
Okay, give me.
Okay, so we going to from the angiogram point of view, this is LV. You see the RCA picture? We should show the RCA.
Next.
The right was
Very-
non-obstructive, yeah. So left,
Sure.
as we showed, a lot of calcium, and we're going to take a better engagement. We did try some catheters with the Voda. What did you try, Anno?
Yeah, VL. We
VL tried,
couple
they
of
did
them.
not fit in because of the narrow root and this calcific eggshell. So we are taking the picture of that. So while we get a left-sided picture, let's come back to the our slide presentation.
I mean, truly unusual in that such
Yeah.
heavy calcification on the left
Yeah.
and absolutely nothing on the right.
Right, exactly. That's it.
Amazing.
So this patient also had some restenosis of the OM branches. We'll show you that. Score syntax of 39. And after heart team discussion, because of the age and calcification, surgeons actually suggested that we do high-risk protected PCI. One of the reasons was that there is no option in this case for going for cabbage. So it is just whatever we can do in the cath lab. So because of the only mild LV dysfunction, but extensive CAD and left main, we thought it's an appropriate case to use the Impella device and do, of course, imaging, and then rotatripsy because of calcification and with the Impella assistant. So from our point of view, we know that this case will be M, intermediate high risk finding with no diabetes, but after heart team discussion, I would say these cases become appropriate. So now we are ready. We can go to the angiogram, please, and continue to show imaging of. Yeah.
You have already answered the several questions which were regarding the need and use of the Impella catheter, and glad you took care of that right away.
Yeah. So this is it. Yeah.
Is the Impella a little needs to be withdrawn a little bit, or?
So actually, nowadays it's also the optic sensor. They tell you if it's too far
exactly.
and too in. Any guys, Impella position is good.
Exactly right. Yeah, you don't even have to worry about
yeah,
that.
the caudal view a little better. Caudal.
No, I'm trying.
Let's see.
This is where we are.
Yeah. So
And
this is here.
This would be a 7
Go to
French, no?
Yeah, this is a 7 French. Now finally FCL 3.5.
FCL, yeah.
No, go to areocaudal. I think you need areocaudal now.
No. If you have to have a wire,
very
that's
angulated circumflex. You see the retroflex circumflex? We have the fine cross and everything ready here. Where is fine cross? Huh?
So I can tell you that in the submitted cases which probably the audience got, they never saw this view, which demonstrates the severe, I think the origin of the left circumflex is challenging in every way here.
Absolutely.
And even in this view, it is masked.
Yeah, this is it.
Okay, now we see it, and severe calcification of the distal left main, origin of the left circumflex.
Get a 1.75 bar or
1.75 bar.
Yeah, and get a 1.75 bar ready.
Filter wire, please. Asif,
Filter,
wire.
you have that, right?
Yeah. You guys both have the speaker? Yeah, good. So we just want to make sure that all they have. Good. Yeah, this one cover right now because I don't think we need to do with such a calcium. A lot of people will be, I would say, they will do still the imaging. To me, I don't think imaging going to help anything here at this point. First, you open some, do revascularize, and then you can do imaging. So here, imaging may sometimes even create little trouble because of lifting the plaque.
I mean, at this moment, I want to provide a wonderful guidance to our viewers.
One second.
You would be noticing that most of your questions, several of them we try to answer, several are left alone, and they are all answered by Dr. Sharma at the end of the case, and they are posted. And exactly what Dr. Sharma mentioned just now was tackled in, I think it was question number 4 or 5 from last month, that in such severe calcification, you probably do not even need imaging.
Yep. At the outset, you may need in the sometime maybe middle, but more important in the end, yes, but definitely not at the outset.
I don't know what we teach this. Everything is wrong.
Okay,
So I hope that the viewers are able to read those questions. Some of them are exceptional answers, which are highlighted for your review?
Balloon 30,
Yeah, get it.
30, 15,
No, 3-5. 3-0 is good.
30,
20.
15.
Good.
I'll be too late.
Let's see, little die.
Maybe
Now you're
flush.
going to the circle.
Yeah, right?
No, we have to go LED first.
Okay. LED has
What
two
have you done?
lesions. Let's go to epicranial then. So there is a clear-cut, very significant lesion in the mid-LED as you saw earlier.
Exactly, which I think probably needs to be addressed. That
Yeah,
would be
yeah,
causing a
yeah,
lot
yeah.
of ischemia.
Let's go to
There you
this
go.
view.
That's the right view. Yeah. It's a very large LED.
15.
Yes.
And of course, a 7 French guide, no?
Yeah.
So straight away, a question for you. This is from Dr. Mahmood El Rais. Left circumflex angle despite retroflex is favorable for provisional stenting.
Well,
Not sure about that.
yeah, so, but remember the provisional stenting, if there is a lesion and there are multiple lesions in that OMs further down. So those are the cases, if you know that there is an inability, the difficulty in getting the vessel side branch there is a clear-cut point in the definition criteria that if you have trouble in getting access to the side branch, so that case should go with the two-stent approach. So let me tell the person who has asked the question is quite intelligent, but it has to go through the regular process. So if you ever have to do any stenting in that artery and you have not done, and you're thinking doing only provisional, and now you have to do bailout, which could happen in 10-20% of cases, then you will be in a big trouble. So this is the case. You definitely want to take little better. See, you saw that there is an ostial circ disease, and there were a few disease in the OM branches also, because there have been a stent in the OM. Let me show you that. See, there is a very tight lesion in the circ. We are going to go back here again, right there, and more important here. See that? There is two branches of the circumflex. You probably will try to open one, and the lesion there is. So therefore, this kind of case, because there is a trouble in accessing the side branch, you want to go with a dedicated two-stent approach, because that way you are fully covered. Now, second point, if there is some region, in this case, an elderly patient, there is issue about the depth, maybe that situation, you might want to do the single stent approach. But the only thing is this patient had lot disease distally, and therefore you want to cover that circumflex. You see on the top, angulation, and there is ISR of the old stents. And what do you think? Your approach will be one stent, two stent here?
Let's see how we are able to wire the circuit and then make a decision.
No, but yeah, we were able to get the wires. One second. This. No.
I will
Release,
be.
release, one second.
I'll truly be surprised if it is a single stent.
Yeah, sorry.
Yes. Shit. Like,
Okay, now patient, we already got the hemoglobin and all. Patient is on heparin. And patient has been loaded with clopidogrel, and patient was taking it before? No. I see. But CRP is 19.2 now? Wow. No, patient has troponin already 207. So that's the baseline means it's elevated troponin. By definition, it's a non-STEMI at present. Patient may be having some pain.
The mid LED which is doing it.
Yeah, mid LED is very thrombotic, way more than what it was last time.
Yeah, probably needs.
Yeah, we have the balloon and everything ready. And
Right.
clearly, always get a balloon ready. Good. We are going to check. Ready? Good. Okay. So 155, it comes set on there. This is a rota floppy wire, and we are going with a 1.75 bar. And we have a 3O balloon ready on the table in case it needs. Right away, I'm going to pull wire. It's a little distal. Yeah, yeah. So we are going to, once we are reaching there, we'll put the wire a little bit. Just hold on. Let me pull the wire. Yeah, good.
The wire back.
So this case, we used, with knowing that the guide will be a trouble engagement, we always say the single axis in the Impella with a 14 French, you can use up to 7 French guide, but this case we knew that it will be a difficulty, so we have 2 separate puncture. Impella has been placed from the right side, and this is on the left. I have to pull back a little bit. You're on the distal there. I think pull back a little bit.
150.
Yeah, good.
50, 5 seconds, 150, 10 seconds, 150,
Good.
You have the IVUS ready? Huh?
155,
Good.
20 seconds.
Good. So first lesion went with a 20-second hemodynamics remains same. Unchanged. The whole goal is that you don't need to burying in when it is a double digit. So always has been 100
10
plus.
seconds, 50, 15 seconds, 150, 25,
Yeah.
26.
So it has gone to
Advance
the
the wire
second
little
lesion.
bit.
Yeah, it has
Advance
gone
the
through
wire.
the second lesion, but only thing is there is the angle need to be taken care. Go. And see, if I have to advance the wire, I can press the brake and then I advance.
Seconds,
But it's in the branch.
That's why
Yeah, I think
didn't want it there.
you have to press
That
the
was a
brake.
nice U-loop. Why
Yeah,
did you separate
earlier.
it?
Then it came out.
15 seconds,
I think we should leave this alone because it's maybe
Yeah.
too big for that angle.
Okay,
Right.
good.
Yeah.
Come off.
So,
Yeah.
many questions have come.
Mm.
Uh,
Yeah.
Let me try once more. Once
No.
more.
One more? Okay, 1 second then. 1 second. Yes, question?
So,
Advance wire.
a few people have actually wondered whether it would have been one fiber.
Yeah. No, I mean
Not
for the...
for the left main. I mean distal left main to LAD, yes, 175. But here I'm not able to make that turn. So I think we're going to come out. 175 maybe
Just one
large.
more try. I pull back the wire. Let's see. It may be less wire bias now. Do one more try.
150,
Yeah.
45, 5 seconds,
No, it does not have the support either.
Okay.
Yeah.
50,
That's fine. Good.
very extremely angulated
Yeah.
there.
Yes,
And
yes. We're
The
coming out.
next question is, would this be a good case for orbital?
Yeah, I mean orbital is reasonable also here. Yes.
And then there is some speculation as to, have you been able to establish criteria where with an Impella you use a single sheet?
Yes. Yeah. So question is the sheath, although they have this modified 7 French sheaths now, which called what is the name of the? They made a new name for the sheath. Introducer or something. What is the
Not
name
the
of the?
not the
Impella?
easiest to
7
use,
French sheath.
really.
Yeah. So, but only problem is the movement of the guides are very difficult.
Right,
So if
right.
there is a trouble in guide, so we do not use the Impella sheath. We don't puncture the same and go to the other side. Now, only question is, there is no, truly you don't need Impella CP, which is 14 French, code good 13, but that LP is no longer available. So they call it a
Companion.
yeah, companion sheath. I knew about
Be
low profile
companion.
companion sheath, 7 French, and so.
See, the only thing is with the 14, the single axis, okay, when you're doing large bore axis, I know a lot of people initially promoted that, but I
Always a challenge.
all a challenge, especially when you're doing left main,
Disaster.
yeah,
Disaster.
that the between the Impella and the guide, the movements are not easy. That's one. And the other thing is, whenever there is, I know we are ultrasound guided, we are doing a lot of the large bore axis that way. If you have
fine.
two axes,
root
right,
wire
you
out.
can close the impella, and then you still have up and over way of making sure that your large bore axis is well closed, you know, before you then have another axis ready if there is any issue.
Right. This patient, you plan, if everything goes fine, to remove the impella in the cath lab?
Yes, yes.
Yeah.
So one other criteria, I think, when you're doing pre-close, you need 2 pre-closes. So you'll see calcium. And if your 2 pre-closes have taken well, and you know you will be able to close later, you can probably consider
Get the
maybe use
IVL
single
3.5.
axis.
IVL
If there's
3.5.
only one pre-close, the second pre-close is you're not able to deploy, then I think 100% you have to go 2 different axes.
So in this case, were you able to get 1 or 2?
No, we planned here because of the left main and so many, I mean, heavily calcified aorta. We thought that we will not be able to, but we got 2 pre-closes.
Excellent.
Yeah, but we still have 2 axes. Good.
Yeah.
Yep.
So you see that despite not able to make the turn, we probably were able to do at least 70% of that lesion there. So it's okay.
And this is the point we have been making, the incomplete rota. You don't have to worry about the whole segment. As long as you have done 70-80%, you have cut the interelastic membrane and your balloon will expand, like here. So, and particularly angulated, you want to get away from it. You don't want to go to that angle and have an issue about the dissection or perforation.
Why did we open without imaging?
Yeah, no, yeah, that's okay. We'll do the distal, yeah, here. There you are going to need the IVL.
Yeah, but
so distal,
size we should have done by imaging.
3.5, yeah, 3.5 we have. Okay, so now we are going to take a picture and I was now. This is the time you do the imaging. Ready?
So there is another question that would it have been appropriate to wire the circumflex also at this stage?
That's a
Yeah,
good point.
that
Yeah.
would be a good point, and most people will. But only one thing that I would have done different is never open the IVL until you've done the imaging and you understood exactly what is the diameter and for the IVL balloon.
Okay. Good. Okay, we are ready here. This is the IVUS.
So Samin, the IVL would be only for the distal left main and
I
the
think so.
proximal
Yeah,
LED?
left man. Yeah. Yeah.
You
No,
will not, you
right
would
now
not,
let's image. Yeah.
Yeah.
you
and
would
then
not
see.
go to the mid LED.
I think it looks okay mid LED now.
Right.
Right? I mean,
Not-
it's a, yeah.
Not much
Based on our
calcification
previous
left.
criteria, it has opened. After rota, we saw a full expansion with the balloon. So good. Since it is distal left main and there is the length of the left main is long enough, if someone says, oh, I would have done OCT, not a bad choice here. Okay, we are going 1 millimeter here, not the usual fast speed.
Okay, start.
1 second. Recording.
Still a lot of calcification there.
The floor we are there.
Nice
Yeah.
cuts.
Look
here.
at that.
Yeah, let up cuts. Yeah.
Bookmark.
Nice cuts.
Yeah, another cut. Bookmark.
3 quadrant. At
Yeah,
that
the four
significant,
quadrant.
no, no,
Four
at the
quadrants,
significant
yeah.
thing.
Yeah.
3, 5.
Are we to the left main yet? Let's
Not
see.
yet, not yet, not yet. We're not at the
Still
septal.
coming?
So here, lumen is good despite calcium. This is prox LED now.
This is small here.
That is a distal left
This
main.
is small,
Yep.
yeah.
Circular calcium, 360.
So
Okay.
I know exactly what the information you needed prior to using IVL. And I think
No, IVL we know
What is the vessel
we had
size?
to do only I want is the diameter. Yeah.
375.
So come back to the Austrial LED. Right there. Yeah.
There?
Yeah. Yeah. Okay. 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 Okay.
Here,
Right.
right?
Okay. Right. Yes.
Yeah, this is the one.
Yeah.
You see, there are little cuts there already, but hopefully IVL will give some more cuts.
Should we get the vessels?
Show me proximal LAD. Proximal LAD at the level of the septal.
Keep it covered.
Go back. Yeah.
On
A
the
little bit more inside. If someone says they want to wire the circuit right now, yes, not a, no, I want, oh yeah, keep coming
Get a
back.
fielder
Coming
wire
back.
because
Yeah,
we have
no,
to
no,
do it.
we have it,
Yeah.
we have it, not now.
Yeah.
Okay, there, come back,
Like 3 point.
back.
more distal?
Not distal. Come towards the left main. I want to see at the level of the septal. I think there is 4 quadrant and then, yeah, right there, yeah. So it's about
No, adjust.
3,
This is
5.
totally off. Yeah.
No, that could be off. I'm looking at the diameter. I
Hmm.
think we use the same balloon into the proximal
do a
LAD
sum.
also.
Yeah.
Yes.
Distal
So
left
it's a
main and
large.
proximal LED. Yeah.
A little large, but
So, I mean, a little conceptual clarification. I'd like to get both your feedbacks on this matter. Purely because of the mechanism of action of IVL, that you're truly burning out the lesion and subjecting side branch occlusion should be lesser, no?
Yeah.
Because there isn't really any plaque shift there.
Exactly. So overall, the studies have shown that very low incidence of side branch closure, like less than 0.3%, perforation less than 0.01%. Good. You want to do proximal first or what? You want to start here?
yeah.
Okay. Okay, so we are going to go to 4. It's a 3.5. So then you go to 6 and come down.
Wait. Okay, you have to wait for it. I'm going to pull back. I think that's enough there.
Yeah, if we can go to
Yeah, good,
flow to angio there.
Yep. Okay, go to the angio.
Okay,
Yeah.
perfect,
Now
perfect.
done.
Yeah.
Okay.
Thank you.
4. Six, negative.
Go.
Yeah. This is now getting to the ostial
Ah.
LAD. Again 4.
Very angulated there too.
Yeah. Yes. Okay. 6. Next. Now, once you get to the distal left main, there you can go to 6 and 8. Okay.
No, you don't need. It's about 3, 5.
Okay.
Don't go to
Okay.
8.
Keep it 4. But here, see, it's not opened.
Big waste there.
Yeah.
Ostial LAD, it looks eccentric. I thought we saw
So
3
this
quadrant,
is-
right? 3 quadrant calcium.
In the entire case, I think this is precisely the moment the Impella will help.
Yeah. Exactly.
Good. You can already put the, yeah, you see the hemodynamic pressure is going down to 90. That's ostial.
Let's give breathing room. Bring
Yeah.
back into the guide.
Look at the ST depression.
Yeah.
Yeah, yeah.
And the low blood pressure. So let revascularize. I mean,
So this is in your live cases.
so this way. Yeah. Pressure coming up
Just-
now.
Jaswinder Singh was almost debating this point that he doesn't see this often, and here we go. I
Yeah,
think it
good.
is a real phenomena.
Yeah.
But you
have
remember
to
I
be-
made that point when they
Yeah, you did,
were
yeah.
wanting.
Yeah,
They
exactly.
wanted IVL for the left mains. I said, no, this
Have
is
to
what
be
we
cautious.
face.
Yeah,
Yeah.
yeah.
It, I think, is opening up, although we'll go a few millimeter
we
in
have to go
and
in.
we'll see. Yeah.
I don't think that extentic down. It did not look like a nodule, right, Yulia, there?
Good.
No,
Yeah.
it looks
It
like
did not look
regular.
like a nodule. I think it could be more adventitial also.
You want to go a little further,
Yeah,
but
yeah,
anyway,
down,
not
down,
right
down.
now. No, let's do this. We still have
Don't
a lot of, no, we had to take care of the
Yeah,
whole
yeah, but if
calcium
I
segment.
need for the circ, we can use it down.
Mhm.
Yeah, so another question, which I think we've addressed already, that does IVL have effect on the left circumflex ostium while you're working on the left main and the LAD?
Well, I mean, it's just basically modifying the
Probably,
plaque. Yeah.
indirect. So would you,
Can you say that is expanded or no?
No, I think it's adventitial. Let's not worry about it. Hmm?
No, but many times, even after IVL, you may have to go to high pressure balloon,
right?
408 or 12. Get a 408.
So,
Yeah.
408.
You want to take a
so
picture?
the
No. First, let's image. Let's not. Yeah.
image,
No, Samir.
yeah, so in many ways, protective PCI is in the eye of the beholder. What
Yeah.
may be critical to you may not be, but I'm just wondering if the amount of bifurcating left mains we are using with IVL, would a left main bifurcation using IVL qualify a use of a support catheter?
Yeah.
I'll give you an example because I remember for the audience, I walked Dr. Sharma to his office before the case, and I kind of wondered out that, look, do we need an Impella here? And his feeling was not sure, but I think yes. So, which is exactly, I think, what we noticed here, that it turned out to be, I think, extremely beneficial in this case.
Live.
Yep.
Julia.
Yeah. So, I mean, clear. You saw that blood pressure became
Live,
70
live.
despite our the Impella. And but that's okay because remember it's a double output.
I think it's, I mean, for a moment, I think it may be worthy of a little discussion. That did not happen with even the 175 burr.
Yeah. No, because I'll tell you, it's because of the duration of ischemia.
Yeah.
So even with the IVL, you leave it for a few seconds, then probably you will not have any trouble. But now you start getting to 10 seconds, that's where the trouble starts.
Yes. Go. Yeah.
Ready?
That's why the pecking motion is so important. When you go back forth, when you're coming
Absolutely.
back, there's a little forward flow. So we are at that second lesion.
Right. The level of the septal.
Yep. So
No,
let's
no,
see
no,
the
this
left
is-
main.
no,
What we
no.
need a left main.
Yeah,
We
lot
are
of
in that,
cuts there.
Yes.
Lot of cuts.
Cuts
We
there,
can see.
but
Lot of people believe that your end, that you have done the end of ablation or modification if you see three or
So-
more cuts.
So how do you explain that? If you take a look at it, most of the cuts were between 12 o'clock to 5 o'clock or something, whereas the ones from 6 to 12 are absolutely untouched, which is surprising. And I mean, why should it be significantly only on one side?
So I mean, but it
There's
was
a
circular
lot
calcium.
goes into it because if you really need that, we need OCT. I mean, IVUS does not give you
And-
that
and-
depth of information to
Excellent,
understand
yeah.
what is the thickness of the calcium or depth, and we don't get that. So
Four high pressure.
other thing is, I think you had crack at one level, and maybe it's the same way the plate is. The
So the-
calcium plate is being
One and the other
broken.
thing is that the wire may be biasing your
there you go.
IVL. Yeah. So okay, now so let's question is, I think let's put a stent in the mid LED, then we go to the caudal view, then we do work a little more on the distal left main with a high pressure balloon, and then after wiring the circ. Agreed? The plan.
Now,
Okay.
give me the ostial
Stand.
LED. Ostial LED again.
Yeah.
Yeah, right there, right? Yeah. I think we did a. reasonable
So,
job there.
Yes.
I mean, I think this
Good.
point deserves a little more
3.5.
understanding here. So let's say in this case,
28.
you observe that
Stent in the LAD, mid LAD. Yeah.
What do you want? Synergy?
Anything, yeah. Yeah, sir, you were saying something? Sorry.
yeah, that
Synergy.
let's say you notice the
Synergy,
fractures
3528 synergy.
fractures more in one plane and going, of course, agreeing with both of you that, look, this is not a very detailed assessment and OCT would probably, assuming all of that. But let's say if you were having the fractures on one side, would it be a mistake to go back with the IVL and go a little higher?
No. It's good enough. You have
Right.
1, 2, yeah. It will, the strength
enough.
will, yes. It
There are
Stent will
multiple
expand.
ones.
Stent will
expand now.
expand.
You'll see
Yeah,
the
yeah.
expansion. When you see the final IVUS, you will see.
20.
Got it.
20 or 28?
28, right?
28.
Yes.
This is 20. This is 20.
Yeah. That's okay. Right now, that's okay. Take you.
I know you don't want to stent first the distal of the
No,
two
that's
lesions.
what,
No, that's
what
what
we're
we're
doing
doing.
now.
But
Yeah,
they
okay,
gave
that's
us
fine.
a
20 is
different
okay.
length.
Yeah.
The 20 is
Got
okay.
it.
Huh?
38 may not cover.
We need 28. Yeah. Give us the 28. Give it. Yeah. No, you're right.
Once-
We are doing the mid.
Keep it
I
for
know,
the
I know.
circumference.
Yeah, exactly.
3.5?
Yeah,
It's too
this
big.
3.5.
Oh, no.
No, we'll be okay.
The vessel is
Yeah. Okay. 3.5, 28. Synergy.
the vessel.
XD.
To all our
And coming back to
viewers,
your point,
yeah,
and
go ahead.
coming back to your point that when you have a cuts from the IVL, now your next work could be just by high pressure balloon dilatation.
Sure.
That's all you need. And that will do rest of the job.
Absolutely.
Okay.
Good? We're there. And put a guide a little bit. Guide is out.
Okay. That's okay?
Yeah.
Some die.
Okay.
Good, right?
Yeah. Good.
Okay. Go.
Going up.
You see that expansion now?
Yeah.
You don't even need high pressure balloon dilation once you're done IVL. I don't do post dilation. Sorry, dilation. Yes, after
Completely
IVL.
right, but I think the area where it'll be tested is more proximal, but
Yeah.
very nice expansion there.
Yeah, but the proximal, we are going to do the high pressure balloon, or maybe go back with the IVL, and so then only, good, take it out. Yeah, so if good. Let's take a picture.
No, proximal, it is a lot of adventitial calcium that we are seeing.
Good, let's go to caudal now.
You should leave that area alone. Okay.
So, I mean, many more questions, all extremely well thought through. Using, this is Dr. Hemant Koduri, using IVL in osteal lesions causes any increased dissections?
Well, I mean, there is a little dissections are okay, but the what dissection causing perforation you are worried about, and that does not happen. But yes, I mean, the dissection to me, the limited dissection is a part of our interventional procedure. So we want a little bit of dissection.
Question is which you use for the circ?
Yeah,
This one?
yeah. Yeah, this is the one we had. 3126.
And Dr. Vinod Khandait, I hope I'm not pronouncing it wrong, that would be embarrassing. If it's a dedicated bifurcation plan, what strategy would be good for an 89-year-old?
That's a good point. To me, I think the one strategy still will remain that we have to open up the osteal circ with a balloon, and then open the distal vessel, put a stent, and then you want to do only, there you go, that's good. and then if there is a truly no osteal disease, and come out with the provisional is completely fine for this age.
Right, right,
Yeah.
exactly right.
Okay, let's take a picture. Yeah.
No, even I mean double stent left main not studied, but if you are using synergy stents, he has no risk of bleeding.
Yeah.
Oh, you still
So
have
he
a
could-
lot of work there to do with the distal left main and the circumflex.
Yep,
That's a very tricky lesion.
Other question is, do you need a 4 or 3.75 cutting balloon? Let's go. Let's circ first.
No, distal left main has opened up well. I don't think we need a cutting balloon.
Or now other question could be, you can put, let's put a wire in the circ and put a IVL into the circ area. So some distal part of the left main going into the circ will open up better. The circ remains our Achilles heel of intervention.
When you're using IVL, I mean, this is a pretty severe angulation. Is that a concern with IVL or no issue?
Yeah. No, I mean,
We will see whether it will make a turn.
But do you need to do a regular balloon first? That's a question.
No, that's one. And other thing is it's been used. So.
Yeah. Okay. Now, do you need to do any distal vessel now? If you have to do it, you do it now.
No, that
I know you never wanted to.
Never.
Okay. Let's hold on now.
That's another thing also I think we need to teach. Here we are only doing the highways and the main area.
No, we have the picture already.
Good.
What wire did you use for the circumflex?
A fielder.
Excellent job with that wire. I mean, that was not an easy lesion to cross. And of course, I did notice that for once you used a torquer.
No torquer. No torquer
again.
Yeah. So now
I say the same wires, different fingers, but never torquer. I have used torquer maybe in one CTO case. When
do you want to open that OM right now with a balloon?
I'm not. Let's just focus on the circ and be done with it.
So circ, you want to try IVL? Let's test it. Okay. Good. Okay. We are going to go, and hopefully that, as you mentioned, part of that could be that we could not get the full multiple cuts in the different areas because of the calcium going through more the circ. And now our goal with this will be to just ablate some more calcium, which is on the left main to the circ ostium.
Should I see if IVUS will go?
No, let's do this first.
Samin, before putting in the IVL, would it even help just a balloon dilatation there to facilitate?
No. Before that, let's IVUS.
Okay.
Yeah. Whenever we do IVL, I would like to IVUS and see what is there.
All right. So we're ready with the IVUS now.
Good.
And the IVUS, you were going back with the previously used, there were sufficient trains left there.
Right.
Yes. Not IVUS, you mean the IVL we have.
We still have about 4 more cycles.
4 left.
Yeah.
So we could use that.
Nope. Did not make.
Let's see. Give me start imaging. Let's see, where are we?
Start imaging. Starting.
Nope.
It's still in the distal left main, right?
Stop.
Okay.
Good. Okay. Off. Now we don't even try the IVL. So let's get a little balloon. You want to do a cutting balloon?
No.
Huh? Will be very good here.
No, believe me. Last. I want to say. 2 days ago, cutting balloon did not go. IVL went. So you're making me say it. So.
Okay.
Give me the IVL.
Yeah. No, IVL will not go.
Used IVL.
Your IVUS did not go.
Yes, but still, it's a monorail. This may
Everything is monorail.
Yes. Then we'll go
The
with
body.
the regular balloon.
Okay.
Yes. I mean, short monorail. Very
Look
short
for a
monorail.
2.75 Wolverine. Yep, but keep it with you. If this goes, we don't need it.
Do you want the score flex also? That goes.
Huh?
Score flex also, that goes.
Be very interesting to see how the IVL catheter behaves there.
Okay.
And it went
Okay.
easily.
Went. And that's surprise. I was no IVL,
Yeah,
yes.
because it's a short monorail, and wiring is the one that tells us
4.
the way.
Yeah.
Yes. Yeah, this is 3.5. I don't
That's
think it's a
the
3.5. Yes.
We go to maybe lower. For key,
Okay.
you have to pull back now.
Yeah, I know. Okay.
So the patient
Down.
is tolerating well.
Because now we are not
This
occluding the
time you
left main
did,
to the
yeah.
LED yet. Yeah.
Yeah.
Good.
Okay, now this is what we need.
This is the one. One is short. Good.
Yeah. And the patient's blood pressure bottomed out there for a
Yeah.
moment.
Okay. Now we need to pull back a little more.
I think we are done. Let's
Yeah.
not get.
Good. Good. This is the one.
This
Yeah. Yeah.
You don't need that.
This is the distal left main.
Yep.
Looks good.
How high did you go there?
Now, no, this time I just went 6. Okay.
Truly, Anu,
And
I
8.
think
Down.
this is possibly
last
the
one, finish the last
most
one.
instructional
Yeah.
point of the case to be extremely quick and brief in
one
the
more.
left
Finish the last.
main.
Go.
Let's go. There's one more left. Dr. Sharma wanted to finish.
Leave it. No problem.
Go back and give it to the lady.
Caesar.
So
We
this
want
is a lot of speculation here, but there is a question which is mentioned that what if you had a perforation of the ostial LAD and would the covered stent be occluding the left circumflex?
Of course. If
Yes.
that is the case, yeah.
You still have a lot of disease there. Would be interesting to see
Foro.
with the
Get a foro
imaging
balloon.
there.
Yeah. No.
No. It's just,
Right,
no,
okay.
we
Yeah.
can direct
Get a foro
stent it
balloon,
now.
yeah. So
Anu,
let's
what
open,
about-
open the foro with the distal left main. Still we have to open.
You didn't want to do the more mid portion of the left circumflex. That
No, there's a
itself is
stent there. There's a stent there. Remember, we decided that was the first question Dr. Sharma asked. We are not going distal.
And why
That,
not?
then you have an
pretty severe.
angulated OM branch. You see that? There's a stent, there are 2 stents, and one is almost stent jailed.
Right. So
Yeah,
why not?
that is another live case. Yeah.
Okay. Okay.
Yes.
Got
So
it.
we're not
got
getting
it. No,
into
no,
that.
no, no.
I-
Okay.
I would not
Completely
dilate.
understand.
No, we still have to dilate. There is a lot of calcium there because there's nothing wrong in dilating because they're still there.
No.
Go.
If
It's
you
a
have
foro.
had enough cuts, the stent will open.
Yeah.
You don't need to dilate.
No, but remember, after the stent, the opening may be a little hampered.
No. Not when you're done rota and IVL. You hold it?
Yeah.
But then the rota was only for the LAD, no? I mean, we didn't
no,
do
no,
We
no,
did.
no,
He's go. We
To
are
the
going to distal
circumflex.
left main to LAD now.
Yeah. No, rota did take care of some part of the distal left
Yeah,
main. Yeah.
He wants
No,
here.
but I meant the ostium of the circumflex and the.
Yeah. No. Yeah.
And-
Not for that. Okay. So now we have 408. Focused. 14 atmosphere.
I don't think this did anything, but
This is the cutting balloon.
No.
What?
High
Just
pressure.
a high pressure
High
balloon.
pressure.
Okay. Okay.
Okay. Let's put a stent now. What length you want? A 2. I think we have to stent in the circ also.
yes.
Right. Exactly.
I would not do this step 4.0 because I think what I have seen with this many cases that we've done, that when you have done IVL and we know there is a nice
Cuts.
cut in the
Yeah.
calcium plate, you just go and stent it and post
Just note-
dilatation plus minus. Yes.
Noticed even with the 4.0 balloon and after everything you've done, there was significant drop in the blood pressure during the
Yeah.
Yeah.
inflation.
already.
So the Impella here helped more than
Okay.
what I personally was
So you want to
feeling.
the same?
Yeah.
3.5 or you want a 4.0?
No, there we can take a 4.0, now 4.0 28, another one, and take a 2.7512 for the circ.
So 3.5 sitting there.
Not bigger than that you need?
Which one? Sir?
Circumflex, yeah.
Yeah, or 3O, 3O12.
Rio, yeah, maybe.
Yeah. You'll be short because you may have trouble in making the curve.
Right.
The 3O12.
No, no, SS, if IVL goes, the stent will go.
You're longer?
Now I'm seeing, let's
Yeah.
not have, because there is a,
Yeah, minus. Let's see what the
Yes.
ostial circ, proximal circ. No, I
then
think
it
short
will look
12.
bad.
Yeah. Huh?
I think 16 will make it.
What do you have?
20.
Don't worry about it. 4028, yeah. We'll take a 4028 and 2.75. 12. 12 is good. Or 16. He has 16 also.
Give me 16.
Huh?
16.
16, okay.
So with the 4028, you
Eight.
want to also overlap the previous stent?
Yes.
For first Q75.
Yep. It will cover it.
Yeah.
Get a 4028. The key is the. Okay, let's get the 2.75, 16.
Okay, then 3.5 we had here.
No, that's okay. We'll return it. Yeah.
Okay, so we'll get into the circ first.
You mean you want to think of? Oh, no, this is good.
No, it looks okay, 3.5 low pressure, but anyway.
Yeah, no, the circ is way big. Okay, take this. Let's go to the circ first. Clearly, you want to go to the angulated vessel first.
So I was looking at the LAD. So our first stent, it stops way before the septal, so which
Yep.
is good because you already see decreased flow in the diagonal. Now we are over, when we overlap it, we don't want diagonal may completely go away, but we don't want diagonal to be lost and the septal to be lost. Okay. Going to the circumflex. The other thing is we have a we have a FCL guide, which is not a good support for
Good
that.
for the circ. It's not good for the circumflex.
That was the only reason we probably needed us 16. Now what we could do, we have a balloon, right? Give me a balloon. 3.5. What is a
3.5
balloon?
balloon.
Any balloon.
Any balloon, yeah. The question is we do anchor and try to push it
Yeah,
down.
push it down. Otherwise, you have to go to the 12, the original we
We
thought.
have 3O balloon.
May not go. Give me 4.0. You got the 4.08, right?
Yeah, this is the 4. Yeah.
So we're going to anchor. I'm going to place this balloon in the LAD. We have the next stent ready.
Yeah.
So you also have seen we are working on the circumflex with the IVL, with the balloon and all that. We did not balloon there. You don't see a lot of hemodynamic changes. So if for this elderly patient, I think just having LAD
Good.
revascularized probably is
Okay. 12. Good.
there's a stent, you see that in the circ, right? No, they're probably not allowing it to go.
Only thing is we are not dilated a little further down.
Yes.
We just dilated the ostium.
Mm-hmm.
That is why this stent is not going further because we are not open. Whole vessels are so calcified. Even there is a mild lesion, but that I'm sure it's calcific there also, which has not been taken care.
Oh, no, this is not a...
Take a deep breath.
Okay, we take it out then.
Good. Okay, first we want to do a balloon.
I would go 12 and be done with it. No?
Okay. Get the 12.
Because we don't know even if you balloon, since there's a prior stent.
275 curve.
More questions? Would you consider T-stenting?
No.
Tank.
No, but
Tank
it's the same.
mirror.
The T or crush will be the same.
You have
but
to get a stent
otherwise,
there
yeah,
right now.
Yeah. So T, but the question is we always have come out of the T nowadays because T will unless it's exactly 90-degree angle or 85 to 95-degree angle, it will miss one or other area. So always try to do the mini crush
No, this is a
or
balloon.
DK crush.
There's no stent. What is
Even
this?
like the balloon of the circ, na?
Oh,
No, you want to go with stent directly? Okay, let's go with the stent. Huh?
okay.
What is
What
this
is
now?
this?
This is 27512 balloon.
Ah, okay. No,
Is
I
it
thought
12?
we were getting a stent.
This is 8.
No, 12.
12? 12?
Okay.
12.
So we are opening the ostial circle a little more, but get a 2.75 now. With that opening, do we want to go back with the same
16.
stent?
16. Yeah, we try 16
Yeah, let's see.
again.
Yeah. Good. 1 second.
Okay, go.
You're too far now.
Okay, go. Yes. There's no disease there, see?
No, but little calcium, that's fine. And let's open the ostium.
Mm.
Good.
Okay.
Okay, down. Get the 16 stent again.
Yeah, ready.
Okay, go up here. This is stented area.
Mm-hmm.
Okay, down. Okay, balloon, stent now.
Yeah,
And we have a 4 already.
4 row, yeah.
Mangled, what are you saying?
Mm.
Now we are going back 27516 into the circumflex. Don't connect.
Mm-hmm.
And then we decide what to do. We may need anchor again.
Yeah.
No?
Mm-hmm.
Anchor.
Good.
Good.
Yeah.
That was a wonderful maneuver and shown very nicely.
Connect. Okay, give us the wire. Probably even if it was a little bit biased by ballooning, we probably change the wire bias, which also helped how the stent went in. When we went up with the balloon, there was no disease there.
No, but there is always a little disease. See that?
Yeah, but
Little calcium. No, you need just a little bit of calcium in elastic vessel.
I
Little bit
think
of calcium at the distal edge.
we removed the wire bias. That's
Yeah.
what we did by ballooning.
Good. Okay, this is now 4/28.
Yes.
I think the real proof will be the
Now.
LED stent, how this
Yeah.
goes.
Yep.
I mean, this we should not have an issue.
Mhm.
Guide.
Well, the guide was also giving you more issues with the circumflex. There we go. Went quite easily.
Let's pull back.
Good, right? This is circ.
Good.
Good.
Take a picture. Sir can go a little further in.
Come back. Huh?
I mean, go in.
Yeah, further
I
in.
think
Yeah.
I would not.
And even LED can come back a little
Which
back.
is a circ.
Yeah.
Okay, this
Yeah.
one.
Push
No,
a little
LED
bit.
you want to. I think leave the LED where
Okay.
it is.
Fine. Good. So going up.
With a circ?
Yeah.
Okay, go. Lot of crush, but that's okay. Go up again.
Mhm.
See that little SS on the left vein? I think let's just
I mean,
cover.
how high were you in the circumflex?
14.
Okay.
Okay, good. Down. Okay, now I'm pulling the LED back a little bit. Some more dye, confirm the proximal edge of the left main. Yeah, right. Okay, now.
Good.
Okay, go up. Hey, wire.
Mm-hmm. You're taking the wire out from the circ, fluoro.
You may need a new wire.
Get a new wire. Yeah.
Good.
New
Ready?
feeder. New
Okay.
feeder.
Okay.
New.
That expanded very nicely.
Okay, down. Go up again. So what do you think? 2.5 or a high
Yes,
pressure balloon will make a
2.75. Yeah,
turn, or will
2.75.
it
Yeah.
go?
No, it will make a 2.75. We have. It will make a turn.
Okay. Okay, get us a
Go a little
4.0. You
further.
have 4.0 balloon, right?
Yeah, we have
Get into
408.
that.
We have. Yeah.
No need. No.
Okay.
We are overlapped so much.
Let the pressure come up.
Let's do the pot first, followed by.
Yeah.
Take a picture. Go. Beautiful.
Looking
Very good.
excellent. Yeah,
Yeah.
looking excellent.
Good. So while they are going to just do a finishing touch, which is now simple, going to go back, a little pot and kissing balloon. We go to our presentation, right?
No, the whole case is recrossing also.
Okay, let's
That's
recross.
fine.
Yeah, let's recross first. Good.
Recross, let's spot and then recross.
We have new wire.
Here, new wire.
Now give me the 4.0.
4 balloon.
4.08.
The distal left main and the mid portion looks so good.
Yep,
I'm
very
even
good.
wondering whether even the ostium of the, but there was no disease there
Yeah,
of the
go up
left.
here.
Yeah.
That's a 408.
Yes.
For 24 atmosphere.
No. Don't get crazy.
20. You want to go a little
Already
further?
high.
Left main was what size? It should be 4.5. What was the left main proximal size?
But angiographically, it's well opposed.
Okay.
Good. Now that, okay, good.
18. Good.
Left main. Last time, one of the doctors had asked a question. Why don't you write a book with the, steps and giving pearls of how to do this procedure? We have the apps. If you go to complicated website, we have over 700 angiograms, like 80 cases of a description of all the cath lab complication, all the cath lab and in our apps we do describe a lot of this procedure with simple steps how to do them.
Good. So now we are going to recross. Now question is, do you want knowing they're still angulated, you want to go with a 2.0 compliant balloon first?
Let's see how it goes and then we make a decision.
We are 2.5 ready? 2.75 we have?
2.75 high pressure anyway we need.
Yeah.
Have a 2.012
Yeah.
balloon.
212 compliant. Yeah. एक पकड़ना मैं ग्लव्स उड़ गए ग्लव्स
This is the fielder wire. We usually go through the stent struts with the hydrophilic.
7.5 this it's okay.
I think you need a 2.0 balloon first.
There's a fielder wire.
Yeah.
Yes.
I think a 2.0 balloon.
Even a 1.2 balloon.
Yeah. No, 2.0 will be okay. 2.0 will make. Yeah.
Oh, see that?
Well, the guide is working against you too.
Yeah. So CL very good for LED. It's not good for no. It's in some small branch.
Anu,
Get a whisper also, yeah.
Glad you mentioned it. That let's show this live.
You saw it, wire does make a turn, then it buckles up. So we probably need a little more hydrophilic
Buckles
slick
up
wire.
and
Yeah.
moves into some small
Yeah.
OMB there, I
Right.
think,
Yeah.
right at the
So we
origin.
can look at the or whisper wire.
Maybe a little
Now the tip is probably gone,
Yeah.
and it's getting into the
little caudal
Yeah,
projection.
no good.
Yes, we can. Okay, get me the new wire.
Okay. Yeah. Take that out. And throw it away. Yeah. Let's get a curve in the whisper. Whisper.
Almost just before you withdrew it, it had
No.
cracked down
Actually, we had
further.
a first.
Let's see. This was the last. No.
No, what's happening here? It's not a good wire for the side. Get another fielder.
This was the whisper.
Now it's a
Yes.
whisper.
I thought that would work pretty well. But, it's the guiding catheter working against you.
Do that. Oh. Okay. Give me the fielder itself, because I never like the whisper wires.
Yeah.
They can watch side, do your things, because I have to be going there by already 9:30.
No, but do you want to show the wiring first or no?
I will get through there.
Okay. So I think while the attempts are made to go into the branch, but yeah, it will be the going back to the fielder.
Is Andrew there? Let him bring me the slide of a fielder wire and a whisper wire side by side.
We've never really had any great success with it, but there is a question regarding a double lumen.
I know. So that's always they ask the question. Maybe we need to become a little master,
No, it's
we
not
don't
a
do
master.
it.
It's
Your
like
other wire is out also.
Yeah. People are asking. I want to know if they have been using it and they have succeeded.
No, a lot of people use it. Even live relay. I was moderating 2 years ago the TCT, and they use for the going into the circumflex. Use the catheter, twin pass.
So, Samin, a very, very good question. I think the answer is going to be a clear yes. In resource-limited setups where Impella is a luxury, should one attempt such a case with intra-aortic balloon pump?
Yeah, absolutely yes. Yeah. So I think clearly we know that real case of a low ejection fraction of 15-20, high EDP, maybe that case is absolute for Impella. But everything else, in my opinion, can be done with the balloon pump. Yes.
Particularly considering, and again, this is an issue we have discussed at length, the cost. The cost of the device is totally, absolutely prohibitive in many parts of the world.
Yeah.
I don't even think you have to talk about truly developing countries. It's a very high cost.
Yeah, exactly. And then there, because it's a single product, in next 2 years there will be at least few more, and then the price will go down.
Half a dozen more, maybe.
Yeah. Yep. So one of them is the trial called Picante. Will be starting. I am the PI with the comparing. It's a Cardian. Yeah.
Excellent
small
job with the
branch.
wire. Excellent job.
What is this?
2.
2. Yeah. You're in a very small branch, but that's okay.
No,
So
what I need is anchor. This is not going to go easy. I need anchor balloon in the
No,
LM.
no,
let's
no,
take this
no.
first. Because,
But the wire you used was a fielder.
yeah,
Yes.
fielder.
Okay.
Yeah.
Samin, you were mentioning about the other device you've been
Yeah.
using.
Yeah.
Sorry.
So there are the two. Two are the 9.5 French, which one is the magenta, and second is Impella ECP. Both. So Impella ECP has done their single arm trial, and they expect it will be approved by second quarter of next year. So this is not talking about 9 French. Now Magenta is going to go into the trial soon, and that is a Israeli company which we did 15 cases. So let's open. Yeah. So that's the one. Now there is another. The other question is
Good.
there is
We use the
Supira.
same 4 down for
Yeah.
the
There is another
casing.
case, Supira.
Like
Another
small.
also like between 9 to 10 French. Those are the 3. Now there is another with Guardian, which is the 14 French. Impella type, same sheath size, and that's the trial we'll be starting now.
Okay, done.
FDA has approved it. It will be randomization with a 30-day endpoint, 90-day endpoint. Sorry,
So
against Impella.
what would be the, okay?
Yeah.
That's what I was thinking.
Yeah.
That if they are going back with the 14 French, then where is the advancement there?
No, the right now is that another product available. That's it.
Right. It'll probably help
275.
us with the cost.
Yeah,
and
exactly.
Give
competition.
us a 4 for the.
Okay, so they'll just complete the job now. You want to just take the last picture and then
275.
you can finish it, and I just do my things.
How was your experience with the magenta? The
Very good,
9 French?
very good, very good.
It is looking
Easy,
excellent there.
excellent. Yeah,
275.
we just do the kissing balloon now. 275 for the and 40 for the LAD and 275 for the branch. Okay, so let's go to our presentation now.
Is he coming?
You know, I would
Why not
encourage
tapping
our
the OR?
viewers to watch this case today, which I think had so many teaching points. Starting from the use of rotational to the so many numerous teaching points with the IVL. Samin, please proceed.
Super. Okay, so
You
this
have
is
to
where,
go with your super fast speed today.
yeah, I know we quite a bit, and then we'll leave it because lot will be right there. So goal will be now, there are a lot of interventional trials of physiology and
This is
imaging
275.
which has come out. Going to go 5 of them very quickly, and then the impact of the incomplete left main
275
revascularization after
275.
PCI. Exactly what we talk about the circumflex issue in this case of the 5-year data of the Excel trial. So basically, let's talk about first the
but
OCT
didn't I
target
tell you, hold on,
3C,
give me the
comparing
4 first for the
OCT,
LAD.
angio,
Let me
IVUS
anchor
in the
it.
calcific lesion from China.
Anchor.
As you can see here, about the 500 total patients, 400 total patients, baseline kind of similar, except OCT cases were a little more complex, longer dilatation stent and longer stent use. But otherwise, basically was that stent factor, total stent length, all was a little higher in the OCT group, smaller in the angiography group, which same because with the
Don't make
OCT
noise,
they make
guys.
you to
Looks
use
like
more
you don't listen
stent,
to when
and
I
then
train.
immediate outcome of the procedural. Basically, as you can see, very safe, no complication of the OCT or IVUS. Of course, with the angiogram, you can see there at the bottom, and of course, great success in all the cases. Then the final post PCI, your minimum stent area was identical, no difference, 4.85, 5 for 4.69, slightly higher with the IVUS, but no significant difference. And the
Correct.
primary endpoint
have a new
after the
275
clinical
balloon or
outcomes,
no?
which is right here, slightly numerically higher in the angio with the target
Yes.
lesion failure. But other endpoints were similar, but the endpoint was angiographic follow-up at the 13 months,
Tell them,
which
wait.
was the in-stent. As you can see, in-stent minimum lumen diameter and late lumen loss. Late lumen loss was the primary endpoint. You see much higher late lumen loss with the angio guided versus OCT guided. And this is the number here. Late lumen loss 0.21, 0.26, 0.31. So no difference between the OCT and IVUS significant difference, although definitely better with the
Okay, go up with the
OCT.
lady.
But with the when you compare OCT with angio, it was better in the OCT group. So that's one. Secondly, doctors left main trial, which has looked into the various aspects of the FFR and so. So this was the OCT optimizing results of the stenting of the left main. This is the OCT guided versus angiographic guided, and primary endpoint was FFR value
This will
measured
destroy
at
the
the end of the procedure in the main vessel. So remember,
Get
the
us a
doctor's
regular
trial was
2.5
also
balloon, regular
FFR
2.5,
in the native vessel, and this is for the
2.5
left
valve,
main
2.5
basically.
12 compliant.
And they had clear cut
2.5 valve,
endpoints,
regular balloon.
the secondary endpoint with the OCT criteria, and so the 1 year follow up, and basically procedural characteristics were there, no difference in complication. Post PCI FFR was identical whether angio or OCT. You can see here, and clearly that more than 0.9 was slightly higher in the OCT group, but was not significant p-value. But key is that post-procedure FFR was identical. OCT finding as a
The IVUS are
MSA,
dead.
and the clearly is identical, no difference except malopposition was much lower in the OCT group, which we know always. The MACE at 1 year, 13 months, identical between two strategies as well as the clinical driven TLR. So basically is that while doctors left main trial did show that there is no significant impact on the functional results of the FFR and impact on the
Really
MSA,
high.
but
20,
PCI optimization and procedural success was a little better, and there were TLR was lower in the OCT group compared. Then Ultimate 3
You got
trial,
20.
which was from China, and basically comparing intravascular ultrasound versus angiography guided drug coated balloon. So now we are talking about imaging after drug coated balloon, angiography versus IVUS, and again 200 plus patients. Bailout stenting with the techniques happens in a very small group of patients, as you can see here.
Good, right?
Minimum post procedure
I'm coming down.
MLD, definitely you got better in the IVUS group, which was
Get
the
the IVUS.
acute gain. The complications others were no different. And then very important is your endpoint. Endpoint basically was the in segment late lumen loss, which was lower into the your IVUS guided group compared to angio guided group, and better the diameter stenosis. And these are the individual endpoints, numerically better in the IVUS group, but not significant. So therefore, the study
IVUS.
demonstrated that IVUS guided drug coated balloon angioplasty is associated with a lower late lumen loss in patients with a de novo without any outcome in terms of the MACE. Then IVUS ACS. The DAPT ACS and IVUS, remember this is the 2x2 factorial design trial. The patients were angiographic versus IVUS, and then within there they have the DAPT basically giving the stopping all patients got ticagrelor, and they stopped the aspirin at 1 month. So basically what did you show? That IVUS guided versus angio guided, target vessel failure, lower with the IVUS guided versus angio guided, so also lower MI, so also TVR, and stent thrombosis. Remember, it's always the same story, that decreased by half, 50%, as shown here. So these are the individual endpoints. Target vessel failure, that IVUS guided intervention had almost half the event rate compared to the angiography guided. So therefore it showed that the IVUS in contemporary drug-eluting stent associated with a lower target vessel failure. Then we have the prognostic value of the post-stenting FFR after image-guided optimal stenting. This is the IRIS FFR registry. Idea was that if you do a imaging and then you do the stent and then you see the FFR, which one does it impact? So these are the clearly the intracoronary imaging, guided lesion preparation, stent sizing, and post dilatation. They call it IPSP. So once you did that, clearly that you get a better individual parameter which we expect, and the independent correlate to the post stenting FFR was LED always have a lower FFR compared to any other. And then the 5-year prediction of the TVF is shown here, but more importantly was the imaging guided PSP, and then you check FFR, which one has a better outcome. As you can see, this is the target vessel failure, and then more importantly, individual endpoints are all superior into
No,
the
go to the distal.
post-stenting with the PSP group
At
versus
the distal
otherwise.
left main,
So
distal
this
left
basically
main.
is the central
Distal
figure
left main.
just to show
Distal figure.
that your FFR, you clearly have, let's say, more than 0.86 or less
Yeah,
than
yeah, right
0.86. IPSP group versus no IPSP group, that you have a better outcome after the imaging group. So means once you do imaging, FFR didn't matter. And that basically the conclusion was that post-stenting, FFR showed a significant association with cardiac events. However, its
Okay,
prognostic
ready?
value
Final
appeared to be
picture.
limited after the application of an imaging guided optimal stent strategy. So once you do imaging guided, you don't need the FFR. Many other trials have shown that FFR may not add much to it. And this is nice, the editorial from there. So coming back to the last one, the focus review of the month, which exactly was for this case, which we have. The impact of the incomplete left main revascularization after PCI in the Excel trial. And what basically we found, that patients were followed for 5 years and what were the predictors? And they took it the incomplete angiographic or functional or syntax score, and they have a Duke Jeopardy score. You know, the Jeopardy score, I'll show you, that basically turns out to be what really predicted of various kinds of incomplete or complete revascularization based on the Jeopardy, not on the syntax,
Start winning
not
now.
on your functional scoring or anything. So that's the Jeopardy score. Jeopardy, all these lesions are given more than 75%, given 2 points. And you can see LED will get 6, 2 in the circumflex, a marginal, 2 distal, 2 PDA. So total 12 points can happen. And what has shown that the residual, your Jeopardy score of the 2
Where is the
or
slide?
more
Show
than
me.
4 associated with more trouble. You can see there, and particularly the
Yes, yes.
circumflex. Basic difference is the circumflex, that your Jeopardy, because you leave untreated circumflex in majority of these cases. And these are the individual pre and post, but the 5-year clinical outcome, death MI, and so all were clearly that the patient with the Jeopardy score of more than 4 or less than 2, that once you have more than 4, there is higher death or MI, higher periprocedural MI, and show as shown here. So the key is the circumflex, and that Jeopardy score of 4 came from the circumflex. Remember, 2 branches of the circumflex get 2 each. So this is basically not the RCA, not the LED. So we lead to incomplete revascularization of the left main, largely because of the untreated circumflex which we see. And these are the individual univariate multivariate predictors. So basically what we learned, method of the complete revascularization is the Jeopardy, and death and MI is all because of circumflex, not because of the LED or RCA. This is the central figure. So therefore, among patients undergoing PCI in Excel trial, incomplete revascularization according to the residual Jeopardy score was associated with increased rates of death and spontaneous MI. Post-PCI untreated high-grade circumflex lesion drove these outcomes. Because many times, we left them in the Excel trial, but the core lab found there was a lesion 70-75%. Those they count as a disease left, and that really created the trouble. So let's take the take-home message. OCT guided versus angio guided or IVUS guided PCI. Calcific lesion, very good with the OCT guidance. Target 3C. OCT versus angio guided PCI of the left main. For FFR and MSA plus minus, because it didn't make much difference. IVUS versus angio guided drug coated balloon PCI native vessel. It did better the lumen area, and then IVUS versus angio guided PCI in acute coronary syndrome, better outcome all the way, better lumen, and then post PCI FFR impact of IVUS guidance was nothing. FFR yes, but IVUS once you do IVUS, FFR was of no value. So despite the advances in the PCI of unprotected left main, untreated left circumflex lesion remains the Achilles heel of untoward outcomes. The incomplete revascularization based on the Jeopardy score is associated with increased rates of death and MI at 5 years, follow up in the Excel trial. Therefore, we need to focus on optimizing circ lesion intervention at the time of original PCI to improve long-term outcomes after left main PCI. So like this particular case, many people may put a stent across and leave that 70% lesion in the circ. Those are the ones going to give you more trouble at follow-up in terms of the death and MI we learned from the Excel trial. Now, 3 questions. Following statement is true regarding the results of the Target 3C trial compared to OCT, IVUS, and angio in calcific lesion. Better MSA in OCT group, more stent maloposition OCT group, lower instant late loss in OCT versus angio group, lower instant late loss in OCT versus IVUS group, and lower 13 months MACE in OCT group. And answer was lower instant late loss in the OCT versus angio group. Second question, following statement is correct regarding the results of Ultimate 3 trial comparing IVUS with angio guidance for drug-coated balloon. Higher procedural complication after IVUS guidance, lower MI after IVUS guidance, lower TVF after IVUS guidance, lower MACE after IVUS guidance, and lower late loss after IVUS guidance. And answer is E, that it was the lower late loss, everything else was equivalent in two groups. The last question, what is the statement, following statement is true regarding the doctor's left main trial comparing OCT versus angio guidance in left main PCI. Better post-procedure FFR in the OCT group, better MSA in the OCT group, lower MACE rates in the OCT group, lower TLR in the OCT group, and higher procedural success in the OCT group. Remember, the left main trial, it basically showed no difference in FFR or stent A, MSA. Only difference was TLR was lower in the OCT group. With that note, I conclude my presentation now.
Put the 2 slides quickly. I have to go.
They apparently have 2 slides. You want to
just
show the last picture? Let's show the
nothing.
last picture first, right?
Last picture you can see.
Yeah. Show the last picture also.
There's a cranial.
Show the angiogram first.
I mean, splendid review. Let's. This is the last picture. Looks absolutely outstanding. The entire distal left
Look at
main, proximal ostial LAD, ostial circ. Anu, any final comments? I know you're showing some slides.
Yeah, just the 2 wires, fielder and whisper. No, we have a updated slide for the, PowerPoint. Just the PowerPoint. Yeah, but the next one, see there, whisper and fielder. The 2 wires we tried, and why I like fielder. I think everybody should try them. Most of the properties are the same. Okay, they're not tapered, 0.014. Now I am going to show you the only difference is a core to tip design. They both are polymer jacket with hydrophilic coating, 1 tip. Okay, now go to the next slide where we show what if you go a little bit up. Next slide. So see how the core, they are stainless steel, but if you see the core to tip design, 1, 2, 3, 4, it's core to tip design. How the design, the inside core is made. You see that? It's nice. Go to the next one, whisper. And the coils are a little different also. But in the core design of the whisper, they call it parabolic. Means it is it goes to one level and then it suddenly tapers down. Compared to, go back to fielder, is smooth. And I know that there's a difference in that when you use it.
Anu, I'm glad you showed it. The only further add-on I can say is use these apps. Will probably give you excellent practical knowledge. Is Dr. Sharma still there?
Yeah, I'm here. Yeah, absolutely.
So, I mean, this is amazing. You know, Ziad Ali's paper basically is exactly the case you showed, the importance of paying attention to the left circumflex and its relevance in long-term outcomes. I also noticed with fascination that, you know, look at how all the PCI is global. You reviewed 6 trials today. There were 3 from China, 1 from Korea, 1 from France, and of course, Ziad from the US.
Global.
Superb teaching points, Anu. Exceptional case today. I hope our viewers have benefited from it, and thank you for
and you can see the growing our app. Go back to the slide. Go back to the slide. Show the slides. Our apps. So Co-op Risk Score came out recently in the last couple of months.
All this information and years of hard work provided free of charge.
Yep.
Absolutely free of charge. Thank you for our participants for keeping the session so interactive. Congratulations, Samin. Welcome to your new fellows. We stop here and we'll see you on August the 20th.